you through about Pompe disease, and the Pompe disease is known with at least 3 different names. It's called acid maltase, and depending on what actually it does as an enzyme. It's also known as glycogen storage disorder type 2. That's again historical, and Pompe is based on the pathologists who discovered it. This is also the condition where, in fact, there was a movie about it called Extraordinary Measure, and a father whose 2 young children of Pompe disease, with high-flying job, ended up giving up his job and find a recluse scientist, Harrison Ford, who is able to help him develop an enzyme treatment. Of course, like many films, it has a story which ends actually with good news, and they found the discovery for it and managed to cure his children. Of course, the real story is slightly different, as I will talk you through later on. So in my talk, I'll briefly outline the historical perspective, biochemistry, and the clinical feature of the various Pompe disease, and how we diagnose and how we manage them. And it's in 1932, it's a Dutch pathologist who described a 7-month infant who died suddenly, and he observed she had massive cardiomyopathy. Not only that, he also made a significant observation when he looked at the histology. He found glycogen actually in the vacuoles of cardiac myocyte. But of course, he wasn't able to name that glycogen storage disorder. It took 22 years before Corey discovered that this is glycogen storage disorder. And then later on, about roughly 30 years later, not just only infant, adult may also present with Pompe disease with similar feature, but predominantly affecting the skeletal muscles. And then in 1963, Hertz described Pompe disease and enzyme defect of acid alpha-glucosidase, and it's also localized in the lysosomes. And another Dutch physician, Arnold Roser, discovered an enzyme replacement treatment, which is now standard of care. So just briefly, glycogen storage disorders in mammalian cells heavily rely on glucose for energy source. Of course, when there is plenty, they have to store it during the day so that some vital organs like brain would have a continuous supply to it. And the glycogen molecule could contain more than 150,000 glucose. But glycogenolysis is really very tightly regulated. Various enzymes are involved in the degradation pathway. But interestingly, when it comes to Pompe disease, it's actually a single enzyme within the lysosomes break down the whole glycogen and release pure glucose without any phosphate attached to it. So really it's quite striking. In a normal cytosolic process, it requires several enzyme and regulatory process, and then in the lysosomes, it's only a single enzyme which releases from glycogen actually to the product of glucose. And of course, this mainly actually affects not the main glycogen lysis organ. The liver is actually the skeletal muscles in the late onset form, in cardiac muscles in the infantile form. And there are various stages. So initially, few lysosomes will start accumulating glycogen, but normal actual sarcomeric structure, so the muscles still continue to function. As the time goes on, the more glycogens are stored in the lysosomes, more lysosomes are involved, and in fact, eventually some of the lysosomes burst and release glycogen into the tissue, and they start actually destroying the entire muscles. And eventually, when the severe spectrum of the disease, really there is no actually muscle sarcomeric structure as we know it, and essentially the myofibrils will be replaced by glycogen, and with edematous tissue, we think inflammation also may have some role in this sense. And clinically, in the broader sense, there are two different spectrums. So there is an infantile onset, which really they don't really seem to have any enzyme at all. And the late onset form, they do have some residual enzyme activity, but as the time goes on, they start developing a disease. And the epidemiology is not very well known because, like many other rare diseases, we don't really have population-based studies. So most of actually the data is gathered from the diagnostic laboratories, and the infantile onset is roughly 1 in 140,000, and the late onset is slightly more, so roughly about 1 in 57,000. The more recently was newborn screening. In fact, in some areas, it could be as low as 1 in 17,000. And infantile onset mainly present babies like floppy babies. They are unable to hold their head on the body, and they are unable to feed, and they will actually have a failure to thrive. And of course, they have significant delay of motor development. As we continue, the other organs involved, in addition to their skeletal muscles, will be their heart. This is very unusual when we compare with a late onset, let alone they tend to have, cardiomyopathy with progress to heart failure or a certain rhythm disturbance, as the first actually description by Pompe himself. And before enzyme replacement treatment, the infantile onset really they wouldn't have survived beyond the age of 2, and the mean age at death is about 8.7 months. And really is a fatal disease in infantile onset form. Of course, now we have enzyme replacement treatment, and we even have patients who are transitioning to adult care. Of course, these actually young people, many of them would be wheelchair dependent, and some of them may actually require respiratory support to the extent they may even require invasive ventilatory support by the time they reach to adulthood. I think it's important to recognize this would have been a disease they may not have survived beyond the age of 2, and reaching that age in transition with disabilities is it's an achievement in its own right, but it has also its own limitation too. The late onset is relatively the same spectrum of a disease, but the onset itself actually mostly starts between the 3rd and 4th decade of life. And there will be patients who will live to, old age without actually knowing Pompe disease. So it's a wide spectrum. It's a slowly progressive, more common than the infantile form. And the skeletal muscles are by and large involved in this cohort, and the heart muscle is relatively spared. Even from skeletal muscles, really these dark red, say, for example, rectus abdominis or adductor pollicis longus or gluteus maximus, these are the muscles heavily involved. So really it's mainly actually what we see is spinal muscle involvement, and the hip actually stabilities. Sometimes the deltoid muscles can be involved. So in terms of medical history, really, when it comes to diagnosis, the late onset is a bit more challenging because it's very insidious in its onset, and any muscle weakness can be attributed to other actually neurological conditions. So sometimes family history might give you some information because especially families with consanguineous marriage, there may well be siblings who are affected. And the progressive proximal muscle weakness, especially involving the lower limbs, are the main issue. And most people actually, even though it's a disease is a late onset, they may not have enjoyed engaging in the sport and physically demanding activities as a young person themselves. And some may actually notice abnormal posture. Someone would have said, "Oh, you're walking a bit funny." And that's the sort of things. And especially walking on inclined surface, climbing stairs. These are really the earliest things patients would have noticed. And of course, as the disease progresses, they can, fall is one of really recurrent fall, being actually, be called clumsy, and they increasingly also require both hands to get out of chair to support themselves. Of course, as the disease progresses, the respiratory muscle involvement, they would have evidence of nocturnal hypoxia. They could be easily fatigued and they can't lie flat easily. Those are the sorts of things really we need to pick from medical history.